Hello, I'm Dr. John Cruz, and today is a question and answer session. The launchpad for that is the video I released a few days ago on antipsychotics for ADHD, and I will start with a 2 or 3 minute recap of that and then be open for questions. The questions can be on that topic or anything ADHD related or anything general mental health related. So the summary is that on the surface, antipsychotics seem to be a bad match for ADHD. Traditionally, ADHD was considered, by oversimplification, but as a deficit in dopamine. The older antipsychotics particularly were dopamine blockers, and that would seem to be a perfect bad match. The more complex answer is that most of our modern antipsychotics are atypical or second generation. So both Abilify and Risperdal would be in that category, are more than simply dopamine 2 blockers. So they are having effects on usually multiple dopamine receptors, usually additional neurotransmitter systems besides dopamine. And even with the old story, part of what's going on in schizophrenia and ADHD isn't just dopamine release, it's the difference between chronic, ongoing, steady, tonic dopamine release and phasic bursts of dopamine released on top of that. And there are reasons that both antipsychotics and stimulants may help with essentially the signal to noise range over time. So jumping back to Abilify and Risperidal, it's sort of shockingly large amounts of these medications are being used, particularly in pediatric ADHD. And my conjecture as to why, in some studies, it's as many as a quarter of kids on one or the other of these agents for ADHD. And that's not just in America, that's been in Japan, that's been in Turkey, it's been in other European countries as well. I think the big push or reason for that is that these are the two antipsychotics that have been FDA approved for autism. There is a huge overlap between autism and ADHD, but I think that many doctors are not thinking too carefully or too closely, and they're saying, oh, the FDA says this is safe and acceptable in kids, therefore I can use it in this condition here. Again, these are not approved for ADHD in kids. And on the surface, superficial level, or the level I was able to investigate, there's dozens and dozens of small studies, case reports, open trials claiming these kids did better on, or showed improvement in ADHD symptoms. Many times these kids had ADHD in a comorbid, coexisting condition as well, such as bipolar disorder or conduct disorder or some measure of irritability. But very few to no large-scale random controlled studies looking at their efficacy. And if I were having my kids treated, they're no longer kids, or little kids anyway, I would be much less comfortable with Risperidal than I am with Abilify. Part of it is that most meta-analyses of side effects suggest that of our 29-30 antipsychotics, including new and old, Abilify is one of the best in terms of low rates of QTc heart prolongation, low rates of movement disorders, low rates of metabolic syndrome. It's not best, it's not completely free of side effects. Low rates of prolactin problems, whereas Risperidal is solidly in the middle of the pack. And there's also differences in the half-lives of the two. So Risperidal leaves receptors pretty quickly. It has a half-life considerably shorter than a day. Abilify's half-life is in 3 days. There are numerous studies or citations and reports to adverse events with drug hotlines where stopping Risperidal abruptly when it was being combined with a stimulant, usually Ritalin, methylphenidate, resulted in extreme physical overactivation, hyperactivity, and the same individuals challenged months later with just the stimulant didn't have that response. So it does seem that part of that is a rebound phenomena. There's also studies in rats that are alarming, suggesting early childhood exposure to risperidol results in greater sensitization to addiction potential for stimulants, more hyperactivity suggestive of an ADHD-like pattern. There's one other bad outcome. So I've seen adults with ADHD respond well when Abilify was added to the regimen. I don't ever use it as a first round choice. And most of these individuals also had depression where it was being added on as a depression augmenting agent. So I think the widespread use is largely for reasons that don't make a lot of sense. I'm not arguing that some kids may show improvement on these, but I think particularly Risperdal has some serious potential for long-term problems. So I see there's already a question, so great. So hi, Mr. AKA. Don't antipsychotics cause brain atrophy over time? Seems like the cost-benefit equation isn't right for kids with ADHD. So I have not double-checked or reviewed how well done, how rigorously done, what areas they're looking at, and what populations or what are they're looking at, because clearly there's evidence, that the prototypical psychotic diagnosis is schizophrenia, and there's numerous signs and evidence of brain deterioration or atrophy in schizophrenia alone. So I don't know how much more extensively those results may be with antipsychotics. I don't know if there are differences among the different antipsychotics. And again, in the old days when I was starting, all we had were the older agents, which most of them were fairly clean, fairly specific dopamine 2 blockers. The newer group of drugs is, you could argue, don't make much sense to even be called a group of drugs, because each of them is working on multiple, usually at least 3, 4, 5, sometimes 7 or 10 different subreceptor systems. And no two drugs in this group are working on the same group of neurotransmitter receptors. And for many of them, serotonin 2A agonist activation is actually it's having a stronger effect there than on any dopamine blocking. So, I would say just for the metabolic and movement disorder aspects alone, in my book, stimulants are probably a safer class of drugs than the antipsychotics in kids or in adults. But different people have different, there may be I had an individual who with bipolar disorder who was probably, I'm not remembering the age when he started, but he had more than a decade of every single year being hospitalized for mania. It was that severe and disruptive. When I started working with him, he had just failed a trial of lithium, and we added Abilify to his other medications. And for the next 20 years, he remained out of the hospital. He had some milder mood, sort of seasonally related mood changes, which were significant, but not to the extent of mania. Anyway, he also developed diabetes, which is a known potential side effect of any of our newer and older antipsychotics. And he had some significant weight gain. He was actually quite, he thought he had won the lottery by being preventing severe manic episodes, which to him, a great trade-off. He didn't particularly care about his weight or his diabetes, which might not be the decision I would have made if I were in those shoes. So we can look at general predilections and likelihoods of side effects, but individuals can choose what they think are the good risks or bad risks for them. So I'm not seeing any other questions coming in. I should have more prepared. I can say two other things. I did just get a notice from Cynthia Hammer. She's the woman who started the, I might get the precise name wrong, the Inattentive ADHD organization. A year ago, she published a memoir of her life with ADHD over, I think at least, it's not polite to mention ages, I think at least 7 decades of dealing with ADHD. And she wanted me to share that her book now has a audio version of it available. So Cynthia Hammer, Hammer, there. No more questions. So I can give you previews. Okay, so Imran, how to function normally after stopping Adderall. So I'm not sure exactly which part of the question. So I'd say there's 2 questions embedded in that. So whenever people stop a chemical agent, there's 2 different questions. One is, what was the agent doing and what is the absence of that effect? And 2 is, and this is a separate and separable question, are there withdrawal reactions triggered by abruptly stopping the medication and how to deal with those? So with Adderall, if it was helping with the range of ADHD symptoms with controlling hyperactivity, regulating emotions, helping with attention concentration, how to function normally after dealing, I mean, presumably, and some of this might be semantics. If you're taking it for a reason, you probably were not functioning normally. You were taking it for a specific condition, which by definition means you weren't normal. So the question then is, what else can I use to treat my ADHD symptoms? And there would be a host of other medications, including stimulants and non-stimulants, to consider, as well as approaches like cognitive behavioral therapy, which can substantially and measurably improve some ADHD symptoms. And I also will take this as a digression to remind people, unlike depression, where often, not always, but often medications completely eradicate depressive symptoms, with ADHD, we are, I would argue, never completely eradicating symptoms. We may be reducing them substantially. We may be allowing people to be much more productive in their lives and in their social lives, but we don't completely eradicate it. So in terms of withdrawal reactions with stopping Adderall, the commonest ones are crash. And that's a colloquial phrase, but crash can be emotional crash, it can be energy crash, and it can be focus attentional crash. So it can be, you can be put below your even ADHD baseline in any of those variables. Part of it is that usually it is a time-limited withdrawal reaction that can go on for a few days. If mood crash is going on longer than that, then either whatever medication is being used to, if one is to address ADHD symptoms, often those will help with mood as well. Some people do need to start something like an SSRI for severe mood if it goes on too long. Trying to get good sleep, good nutrition, good hydration helps get through withdrawal more quickly, less long. So I don't know if I answered that question, hopefully. So Gary DeSlug says, good question. I've talked about this. I'm not sure in which of my older videos. So Gary's asking, is there any evidence for immediate release stimulants being more effective compared to extended release formulations, and particularly if patients can't tolerate extended release stimulants? Is the risk for abuse really a justification to push extended release formulations? So I would say that we have amazingly little data. I mean, the standard recommendation is if you're on X number of milligrams of an immediate release formulation, you should do well on the same number of milligrams with an extended release formulation. When switching to something like Vyvanse, you have to remember that all the milligrams are not dextroamphetamine, that 2/3 of them almost are the lysine. So there's some complexities converting, but there's actually not a lot of data. I mean, one, there's very little data overall showing what is the actual risk of abuse? And here I'm using abuse to mean addiction and abuse, because so many of the studies, and I do have a talk on this, on what's misuse, what's abuse, label abuse of stimulants as anything other than taking the drug exactly as the doctor ordered. So by definition, if you forgot a day, you misused your drug. If you were too scattered and didn't fill your drug on time, you misused the drug. So the term misuse, I think, is highly misleading, because all of the evidence I'm aware of strongly suggests that a majority of misuse, if not an overwhelming majority of misuse of stimulants, is due to symptoms of ADHD itself. If we're looking at, again, abuse meaning addiction and serious escalation of dose to get high rather than for cognitive benefits, I tried to find out what are the rates of abuse with different stimulant. I mean, one, is there a difference between Ritalin and amphetamine products? The animal research and others would suggest amphetamines are more prone to addiction, but I found very little rigorous data, which means there's even less data actually comparing. Most experts' opinion and assessment is that the extended release have lower rates of abuse, addiction, but the data is really weak from what I've seen. There may be new research since I've last looked at it extensively. So, and getting to the question of what's more effective, the simplistic explanation is that with stimulants, we know how much is available at the receptors, particularly messing with dopamine is important, but that there is also some importance, or some of the size of the benefit is relative to how quickly dopamine or other neurotransmitters may be changing. And in that respect, there may be greater benefit to some immediate release formulations, which are surging more. The change is happening more, but then once you're sustained at a steady state level, then that's not changing. So that's how I'd answer that question. So Mr. AKA asks, what are my thoughts on people taking low-dose lithium orotate to increase brain-derived neurotrophic factors and hopefully decrease dementia risk? They say places with high lithium and water supply have lower dementia rate. So there is, to my knowledge, a little bit of epidemiologic data suggesting lower dementia rates associated with that. So lithium, element number 3, it does occur naturally in our world, and the amount of it that's in groundwater, water sources varies community to community. So you can compare high lithium dose to or below dosages of 5 milligrams a day. Lithium, as far as I'm aware, the smallest pill size for it is 150, and it was, when it's used for bipolar disorder, which it still has a track record for being effective for, not that it doesn't have side effects as well, it's usually in at least 450 to 1200 milligrams a day to get therapeutic blood levels. So these are really low doses of lithium. I think the data is preliminary. I've taken a supplement in the past, so that the little data there was seemed convincing enough to me, and the risks at that lower dose seemed meaningful. So I hope I said the risks seem low and the benefit may be potentially helpful. Good morning or good day, Wesley DeVries. So he's asking, would I recommend Risperdal and or Abilify for people with autism and comorbid anxiety, or would this not work very well in general for these kinds of people? So again, there's two different questions. One is it helpful? And two is, are the side effect cost benefit relatively worth it to you? I would say, if particularly you're focusing on, So again, these have been approved, both of these were approved for children with autism. It's not that, so there were measurable decreases in autism side effects in children. We don't know if those extend to adulthood. There's even less research in that population. In my mind, so I didn't frame this well, but the atypical antipsychotics have two moderately common, moderately medically serious groups of side effects. One is movement disorders, and maybe the worst and most prototypical of these agents, and they have a lower rate than the older haldolthorazine antipsychotics, is something called tardive dyskinesia. Tardive meaning slow or late to develop, dyskinesia meaning bad movement, and it's typically a rhythmic movement, most often of lips, tongue, and mouth, but it can be whole body rocking, it can be twisting in other parts of the body. The really bad things about it are that until the last few years, we had no medications whatsoever which could treat it. Now there are derivatives of tetrabenazine, some charging $1,000 plus a month, that can minimize some symptoms. But in the older days, once you had it, it was there and it did not go away. And although it tends not to be painful, I mean, it can, depending on muscle groups, or if I've had people who, bit sore lesions in their mouth or ground their teeth from it. Anyway, it did not go away, and it's very socially disfiguring. The other moderately common side effect of the atypicals is what we call metabolic syndrome, where how people process fats and sugars is disrupted. And often that's accompanied with significant weight gain. Again, there is some difference. So Abilify is a little better than Risperdal, which is pretty middle of the pack or bad in terms of likelihood for weight gain. I mean, things like Seroquel and Zyprexa are even more extreme. And unfortunately, most of those studies looking at those two bad side effects were done in schizophrenic populations with bigger doses of these drugs. For many of the other usages, off-label or not, so when they're being used for autism, when they're being used as antidepressant augmenting agents, even when they're being used for bipolar disorder, many people are using smaller doses, but we have very poor data to determine, are these bad side effects simply a threshold? If you're on any dose, are you at risk? Is it directly proportional to dose? So if you're at 5 times as big a dose, are you 5 times the risk? And again, with something like Abilify, 2 milligrams, the smallest pill, or even 1, can be effective for depression, whereas doses of 15 to 30 are often effective for schizophrenia. So that's a 7 to 15 times range difference. And again, very little evidence of what are the risks of these bad side effects at these lower doses. Is it proportionate? Is it the exact same risk as you're on any of it? We just simply don't have good data to make that judgment. So that was, I think, a side question or aspect. So would I recommend, so one is, like, I'm not supposed to be making any recommendations when I'm talking here, because even though I am a licensed and board certified doctor, I am not the doctor for any of you. I am a intellectual consultant, or hopefully an entertainer, who knows what I am. But I don't have a doctor-patient relationship, so I'm not going to, because I don't know your full history. I don't know what else is going on, what else you've tried, what other family people have had different issues or aspects. Again, I am apparently much more leery of these drugs in general than many pediatricians seem to be. And for anxiety, I mean, 30 years I worked in the Bay Area. I mean, it seemed like people were passing out Seroquel, quetiapine for anxiety. I think it's effective, but in terms of cost-benefit analysis, I'd say even the benzodiazepines do a better job of lower risks for bad problems than Seroquel does. And there's certainly SSRIs and buspirone and others, which even lower rates of serious problems. So that's where I would come in. And between the two, again, I'd say the data to me look much more reassuring, not that it's free of side effects for Abilify than for Risperdal. So the other point I didn't emphasize is that, again, we have more than 15 of these newer atypicals, each of them working in a different way. It's not like researchers looked at their pharmacologic profile and said, oh, this one should be a really good choice for autism, and so should this one. We'll experiment with them first. It's what the drug companies jumped in first and did the studies and got the approval. And all this usage is just based on this is what's been approved. There's no evidence that suggests Risperdal of the 15 other atypicals is the best option for treating autism or anything else in kids. It's that it was out there, it got its foot in the door, and made lots of doctors comfortable continuing to use it and continuing to use it for autism adjacent conditions. So Max Doppler asks, how often do I prescribe mood stabilizers such as lamotrigine to ADHD patients? So there's two, so is an ADHD patient someone who only has ADHD, or is an ADHD patient someone who has ADHD and may also have depression or bipolar 2 disorder or other comorbid conditions? So we know the majority of people with ADHD do have another condition. So I certainly deal with people who have ADHD and mood disorders, including depression and bipolar disorder. So in that context, and lamotrigine is one of the mood stabilizers I like most. It has one really scary, really rare, but potentially fatal side effect where you can get a Stephen Johnson's-like rash where you have essentially third-degree burns develop on your body and your skin sloughs off and you can die. Quite rare. We know that ramping up slowly makes that less likely. Can certainly happen with other medications. But aside from that, lamotrigine tends to be much more tolerable in terms of very low risk for weight gain, very low risk for sedation compared to other mood stabilizers, which include the antipsychotics and include lots of drugs that were originally used for epilepsy. Again, many of which are sedating, many of which have many more side effects than lamotrigine. So I've used lamotrigine with ADHD patients, usually not targeting ADHD symptoms. And I don't think I'm recalling anyone who felt that it helped overwhelmingly with their ADHD, but that's just off the top of my head. So Mr. AKA says, in theory, dexedrine spatials should have similar time for onset of action to dexedrine tablets due to the coating on the beads. What's my clinical experience? I guess not much of an answer there. I'd say I haven't had patients who reported that they saw noticeable or considerable differences between those two formulations. So you're welcome, Gary, to slug. So Imran asks, what are my thoughts on structure, routines, and journaling for ADHD? So there's at least two well-established, well-thought-out CBT for ADHD programs. And again, CBT has a good track record for depression, for anxiety, for other conditions. Variations of it like DBT do as well. On the surface, it's a horrible match for ADHD because CBT requires lots of homework, lots of boring practice. But two different groups, Mary Salanto's group in New York and Stephen Safran at Harvard, and collaborated, I think, with people at University of Pennsylvania, both developed CBT for ADHD approaches in small groups or one-on-one with the therapist. There's a lot of similarity between their approaches, and structure is people with ADHD, almost by definition, do well with enough structure. They don't do well if it's too much, if it's too stifling, if it's too boring. But part of what they have a struggle providing for themselves is structure. So learning how to build your own structure when it's harder innately for you to do it, learning how to keep and maintain structure and routines, learning how to utilize the people around you and technology to reinforce structure and routines certainly is of great value. Journaling has lots of different meanings or contexts. Part of CBT approaches is usually taking notes on what you've done and what worked and didn't work, and what you've observed before certain problems arrive, and what's your response to them. So journaling in that context is an intrinsic component of that. I'd say more often journaling's been studied in sort of mood and anxiety disorders and can have some benefits there, but if it makes you happy, great. If it's helpful, I've also seen people with ADHD who were less clear on what function or what they were trying to do with the journaling, where it became another rabbit hole for unproductive time. So Wesley asks another question. After taking 10 milligrams a day of buspirone, not bupropion, but buspirone, Buspar for 2 months, he developed worsened eye-hand coordination. Have you experienced this with the medication? No, is my simple answer. What I also always say is anyone can have any bad reaction to any drug out there. One of the attractive things to me, and I've used buspirone for close to 30 years, primarily for anxiety, but also to enhance antidepressant action. And I have a talk on it where there is some research and rationale for why it could help with ADHD as well. One of the most attractive features of buspirone is very low rates of side effects, and about the only common one is some people do feel a little cloudy, not overtly sedated and sleepy, but just less alert after taking it. And given that it works slowly and indirectly, not a lot of rigorous data, but I would argue from comparison to SSRIs, where getting a constantly steady blood level is not what's necessary, getting an adequate dose at least once a day. I almost always prescribe buspirone all at bedtime. My thought is, given that that's uncommon enough, one is, unless it's producing wonderful effects for ADHD or anxiety or mood, if you're having worse eye-hand coordination, the first thought would be, unless it's tremendously life-savingly wonderful, stop the medication, see if the symptom goes away. And if it isn't, this would be a reason to get a more thorough neurologic workup, because that's not a good or nice problem to have develop. So hello again, Sniper Channel. So he asks, what is my opinion on sigma-1 agonists such as fluvoxamine, Luvox, and its possibility of enhancing dopamine production to help with ADHD? What I will say, and maybe this is disappointing, is I guess I'm not prepared or on top of it enough to talk about sigma-1 agonists. They didn't even exist when I was in graduate school in neuroscience. I'm being a little flippant there. I know that increasing interest is being paid to them, and I'm trying to remember what other class of drugs. They're now thinking it may be a major component of its activity or benefits. But I'm not fluent enough to say anything intelligent about it, so I will pass on that and I will write it down. So maybe I'll be talking at a later date. So Letitia says, I don't want to participate because She parlait français, and she'll look up later in translation. And Wesley suggests DeepL, DEPL is a decent translator for website software. If Letitia types in French, I did pass AP exams to opt out of a language requirement in college. So I used to be able to read and write it. Speaking is horrible. And my kids went to a French immersion school. So they are fluent and have spent summers in France and enjoying it. So you can try offering, but even without translation, it probably won't be very useful. But so Max is getting back to lamotrigine and the rare skin rash, Stephen-Johnson syndrome, and pointing out that it took him about a month to get to the required dosage. So the other thing is that lamotrigine, the makers of it, after Stevens-Johnson was found to be associated with the drug and found to be associated particularly with increasing the drug dose quickly, they developed a starter pack with, I think it was a 6-week titration to get to. So far and away, lamotrigine, more than most other drugs, researchers have focused on sort of one dosage, which is 200 milligrams, and that's what everyone who's taking it as a mood stabilizer is supposed to be taking it for. There's actually much less use of it as sort of an antidepressant augmenting agent, although it's being used probably at least as much for that. When it's used for seizures, it's used at 300 and above. Anyway, the company came out with a standardized 6-week titration, but lots of pharmacists and others act like that is the only 6-week titration plan you should follow. That's the only one that will reduce your risk. Nobody has ever compared it to 4-week titrations or a linear titration versus sort of an exponential titration. It's just one alternative to immediately jumping to a high dose was implemented, and we don't know whether there would be even lower rates with a different titration or even slightly slower titration. And part of it is that this is such a rare side effect. It makes it really hard to study, and you'd need lots and lots of tens of thousands of people to demonstrate a lower rate of that. Yeah, so Max is sort of questioning my claim that quetiapine is dangerous. So in terms of dangerous, this is to put in context that for years, in addition to ADHD, I work with a lot of people with depression. And although there are fierce critics of antidepressants, and although there are nuisance side effects, and there are rare, 1% of people have more likelihood of bleeding ulcers, but the background in the general population is about 1% to begin with. So it's not hugely escalating it. But in general, many of our antidepressants are very safe drugs without, for most people, ongoing serious medical risks. Again, it's at schizophrenic doses, it's something like 30 to 40% of people on quetiapine, on olanzapine, have significant weight gain, have significant disruptions of fat and sugar metabolism. It's not that all of those people are developing diabetes, but that's not just a trivial lifestyle. So what, it's a few pounds. It's often gaining several pounds a week for weeks and weeks at a time and starting quickly. That is a medically more serious, to my mind, it's categorically different than an SSRI in terms of risk. And the risk of movement disorders, and to be fair to quetiapine Seroquel, it seems to be one of the lowest in terms of tardive dyskinesia and other movement disorder problems, but not free of them. That's another, to my mind, serious risk. And again, the risk is, it's been associated extremely rarely with antidepressants, but even the atypical, the newer antipsychotics were developed specifically to have a lower risk of TD, tardive dyskinesia, and other movement disorders, they do seem to have a lower rate than the old ones, but it's not hugely categorically lower. So many people use them safely, but again, in the San Francisco Bay Area, I not completely jokingly said anyone who winds up in the psych hospital will be put on Seroquel, because they'll be put on it if you're schizophrenic, if you're depressed, if you have bipolar disorder, if you have anxiety, if you have a sleeping disorder. About the only ones going in would be someone with anorexia, might not get it, and even them, if they might get it to help encourage weight gain. So I think it's almost going back to the old days before my time, when we only had a few agents and they were thrown at everybody. Thorazine, throw it at your depression or your schizophrenia or bipolar or anxiety. So Wesley's getting back to the buspirone, and he did stop the buspirone after the eye-hand coordination problem. So if the system and the problems persist, I mean, it's certainly possible that this is a buspirone reaction. Again, it would be an unusual one, and particularly for it to be persisting, it's, to my mind, the greater likelihood, again, without knowing, this is pure speculation, but without knowing anything else about what other medications, anything else going on, to me, it seems like the buspirone was a coincidence and not driving what's going on, and that it's worth getting an evaluation to figure out what might be going on. And hopefully it's reversible and treatable. So thanks, Mr. AKA, who's volunteering information to Sniper about a sigma-1 agonist with fluvoxamine. He didn't see any improvement in his ADHD. So Dennis asks, he's taking Abilify for PDD and Concerta for ADD. Do the two drugs cancel each other out? So some of this was a little more detail in one of the videos about a month ago. I mean, and some of it I described in this recent one. So Abilify, Risperdal is primarily a serotonin 2A agonist, and then with some fairly strong dopamine 2 blockage, and I think dopamine 1 or 3 blockage as well. Abilify is a much more complicated, messy interaction. So its strongest interactions are with dopamine receptors. It's working on both presynaptic and postsynaptic, and it's working as partial agonists, the whole range of activity. And there's evidence with Abilify that it's, and I'm forgetting the term they use, but it actually changes the structural conformation of the dopamine receptors. So the thought is, in different contexts, dopamine, or the Abilify aripiprazole, is more a dopamine modulator. So it may be preventing the highs from getting too highs, the lows from getting too lows. It's a more of a stabilizer rather than just a blocker like Risperdal is. So that makes it a more interesting fit or potential fit, to my mind, for ADHD, where again, it's not just a deficit of dopamine, it's what's your tonic levels, and are those too low or too high, and what are the phasic responses superimposed on that, which are shaped by where your level. So if you're doing a better job of modulating your dopamine baseline, maybe bringing it higher, in those with ADHD from the Abilify, then it's not necessarily working against the Concerta. So there's some evidence, and I'm not remembering what the title of that talk was, that the stimulants, experimentally stimulants and some antipsychotics together are both serving to boost ongoing tonic levels of dopamine release, which may be too low, and by that token, actually lowering the amplitude of phasic bursts on top of it. So not canceling out the signal to noise, but improving the baseline so we can see what's going on. Maybe that's. So John P. asks, do antipsychotics interact with the Vyvanse? So again, the answer is yes, and in complicated ways. And Daddy Deck asks, does risperidone have effect on atomoxetine? So atomoxetine is pretty strongly and specifically a norepinephrine reuptake inhibitor. Risperidone, to my recollection, isn't having direct effects on that receptor, so to that extent, they're not strongly affecting each other. Risperidone is primarily metabolized by 2D6 and to a lesser extent, I think 3A4 isoenzymes of the P450 system. I'm not remembering if atomoxetine has much impact on that or not. So I guess I won't venture anything off the top of my head, but there's a potential interaction at that level. And again, part of it is even if we have drugs that are very clean and specific serotonin reuptake inhibitors, we know in the human living brain, serotonin systems modulate norepinephrine systems, dopamine modulate norepinephrine. These are all modulating each other, even if the direct or immediate effects seem simple and clear-cut. So my advice is almost always start one drug at a time and not starting two drugs within a week of starting each other, because then you don't know what's responsible for what. And start slowly and observe, pay attention to anticipated side effects or benefits. And if you do increase gradually. So Mr. AKA asks, is the shorter height in kids taking stimulants just the result of decreased appetite causing them to eat less? So I don't know if anyone has, part of it is it would be a challenging experiment to conduct in terms of you'd have to sort of force one group of kids to eat more than they wanted to eat, or again, looking at kids who are on stimulants and dividing up how much they are if you could just look at their caloric intake, I guess, but then you'd have to worry that there was some other factor among those kids making some be the ones that were eating more than the other kids. So the supposition is that it's largely decreased appetite and nutrition, and some of the evidence is that kids who take honeymoons, and honeymoons are prolonged breaks from it. So over the whole summer vacation, maybe over the whole winter vacation, so weeks at a time, seem to protect kids from that shorter height benefit. So the claim, so again, that may support the view that it's just an issue of caloric intake or not, or insufficient. So Wesley's suggestion for a video is the health and mental routines from a psychologist, where you show your day and how you stay sane. Interestingly, I'll be traveling the next 2 weeks, so I've pre-recorded for release for the next few times. So the video coming up next week is, if I ever get around to it, my next book, which has a working title of Attention Deficit World, which is about how everyone's at more risk for ADHD, and people who have ADHD are more at risk for more severe ADHD, partly from social media, but partly from other things I've talked about, like lead and plastics in our environment and changes in exercise and particularly sleep. Anyway, so the other one I've just recorded an hour before I got here is on one of the things I teach patients is to treat their news like a medication and get the right dose for them, and different aspects of mindfulness to sort out, why are you scrolling now? Why are you on social media? Why are you on news media? What are you thinking about? What am I trying to attain? Is it just information? Is it some other value? And part of just being more aware of why you're doing it can help you shut off doing it more soon or quickly. So I would say, I mean, I am a psychiatrist. I do have a background in neuroscience as well. No apologies needed for switching the labels between the two, and particularly in the US, and I'm understanding most of the world, psychiatrists are increasingly being slotted into drug pushers. Sorry, I mean, I do prescribe, I do think medications have been useful and valuable, but you need a medical license to, well, there are some exceptions in bending the rules for some psychiatrists with special training, but it's cheaper for insurance companies to pay a therapist, a psychologist, a social worker to talk to people, to do any type of therapy. They want the doctors just to be prescribing medications. It's not a role that I want to restrict myself to. So I think I do more talking and discussing things than many psychiatrists do. So Avatar of Justice asks, is DMAE helpful for ADHD? So off the top of my head, I don't have an answer about the DMAE, and so I will try to look that one up. And Dennis is offering information to Mr. AKA that according to Peter Bregan, that the growth problems in kids who are on stimulants is due to growth hormone suppression, not necessarily appetite or caloric restriction, I guess we would call it appetite suppression. When I looked up, and this was a couple of years ago, I mean, my approach was trying more to see many experts advocate taking weekend breaks or other short breaks from medication, and there was virtually no evidence that either reduces the likelihood of addiction or prolongs the benefit. It may well, I'm not saying it doesn't, I'm just saying it's a really popular claim, and I could find almost no data to back it up, and almost no research on it at all. But longer breaks, again, summer breaks, there is some research, and one of the clear benefits of prolonged breaks for kids from stimulants was preventing that reduction in height. And it's not a huge reduction, it's on the order of about an inch compared to expectations by the end of children's growth spurts. So, or not just end of spurts, end of growing. So the stimulants aren't making everyone, I can't use a loaded or really short people, but they do have a measurable impact. So I need to be going in a few minutes, but I'm not seeing anything new coming in. So maybe something will come as I'm closing up, but stay healthy, stay happy, have a good week. And I'm hoping I'm looking at the right place on the screen when I'm talking. Thanks all for being here. Thanks all for the questions. I'll try to look up those questions I didn't. So I guess Sigma 1 agents and DMAE are things I need to report back on next week. That's all. Bye. letting me